Assalamu alaikum. Now it's a third part of OBG and gynecology lecture, 10 page at a stretch. This is perineal laceration. In perineal laceration, in first degree perineal laceration, there is vaginal mucosa and perineal skin is visualized. Vaginal mucosa and perineal skin is visualized. In second degree, there is vulvocavernous muscle and perineal body is visualized. In third degree, external anal sphincter, internal anal sphincter is visualized. And in fourth degree, rectal mucosa is seen. So in first degree, perineal laceration, only vaginal mucosa and perineal skin is visualized. And in second degree, vulvocavernous muscle and perineal body is visualized. In third degree, external anal sphincter and internal anal sphincter is visualized, and in fourth degree, rectal mucosa is visualized. In second degree, I have already told you that valvocavernous muscle and perineal body is visualized. It derives the vaginal mucosa perineal skin and the perineal body. In second degree laceration, it disrupts the vaginal mucosa perineal skin as well as vulvocavernous muscle. In second degree, in second degree perineal laceration typically have no long-term sequelae because they heal quickly due to high vascularity of the vaginal tissue and do not cause extensive muscle damage. It do not cause extensive muscle damage. These contrast with more extensive laceration which disrupts these contrast with more extensive laceration which disrupts the anal sphincter muscle. Third degree and the rectal mucosa fourth degree can lead to anal or fecal incontinence. These contrasts with more extensive laceration like in the third degree and in fourth degree. Like in third degree, in disruption of the anal sphincter muscle, and fourth degree rectal mucosa can lead to anal and fecal incontinence. Although second degree perineal laceration healed quickly, patients uh, in the immediate postpartum period often have localized pain, particularly with voiding due to proximity of the laceration to the urethra. During voiding, they feel pain due to proximity of the laceration of the urethra and perineal edema also. There is perineal edema also. This pain is normal and it's not a sign of infection. It requires supportive care and NSAID and cis bath is enough. So again this picture in first degree vaginal mucosa and perineal skin is involved. In second degree vaginal mucosa, perineal skin and perineal body, that means vulvocavernous muscle is involved. In third degree vaginal mucosa, perineal skin, vulvocavernous muscle, and then the next external and internal anal sphincter is involved. And finally, in fourth degree rectal mucosa is involved. Rectal mucosa is involved. First and second degree actually heals quickly, but in immediate postpartum period of has localized pain while voiding due to proximity of the laceration to the urethra and perineal edema. So NSAID and cisbath is enough. Obstetric anal sphincter injury. Obstetric anal sphincter injury. Obstetric anal sphincter injury is relatively common with vaginal delivery. It is a relatively common with vaginal delivery. It occurs in association with third degree perineal laceration, which tears the external and internal anal sphincter. Obstetric anal sphincter injury is relatively common, while vaginal delivery it occurs in association with third degree perineal laceration, which tears external and internal, which involves external and internal anal sphincter, and fourth degree laceration, external anal sphincter, rectal mucosa also gets teared. So obstructive anal is usually really common. Uh, Risk factors include fetal macrosomia, prolonged second stage of labor, and operative vaginal delivery. The risk factor of obstetric anal sphincter injury, obstetric anal sphincter injury is fetal macrosomia, prolonged second stage of labor, and operative vaginal delivery. Anal sphincter injuries are usually identified and repaired immediately after delivery. Anal incontinence, involuntary loss of fecal material, and flatus may still occur in the first few weeks after delivery due to labor-related stretching of the pudendal nerve and pelvic floor muscle, both of which normally help to maintain continence. Therefore, patients with postpartum anal incontinence require evaluation to determine if symptoms are due to benign cause like pelvic floor stretching or from breakdown of external anal sphincter. In patients with normal physical examination, normal anal sphincter tone, symptoms will likely to resolve as the pelvic floor recovers. For this, patient reassurance and observation are appropriate. In contrast, patients with weakened anal sphincter and asymmetric contraction and a palpable defect are likely to have an anal sphincter muscle defect that requires additional management. For these patients, the best next step is endoanal ultrasonography. Endoanal ultrasonography, which can locate in and assess the extent of the defect to guide the treatment, repeat surgical repair, and decrease the risk of chronic anal sphincter. So, in weakened and weakened anal sphincter tone and asymmetric contraction or a palpable defect are likely to have an anal sphincter muscle defect, for which we should do endoanal ultrasonography, which will locate and assess the extent and helps to repair the cause. Cause of fecal incontinence. What are the causes of fecal incontinence? Operative vaginal delivery, obstetrician, laceration, and surgery, hemorrhoidectomy, and anorectal surgery may cause fecal incontinence. Another neurologic cause, diabetic neuropathy, MS, spinal cord injury, and dementia can cause fecal incontinence. And chronic disease like constipation, hemorrhoids, rectal polyps, inflammatory bowel disease, uh, infiltrative disease like cancer and systemic sclerosis, and pelvic irradiation can cause fecal incontinence. This is atypical. Pelvic irradiation can cause. This is also atypical that dementia may cause fecal incontinence. External anal injuries are common in women because of obstetric trauma. from prior vaginal delivery and can injure the which nerve. It can injure the pudendal nerve which innervates the external anal sphincter, and can cause direct damage to the anal sphincter muscle. Third or fourth degree perineal laceration, that means external or internal anal sphincter or rectal mucosa, may involve in third external and internal anal mucosa, and in fourth degree rectal mucosa may involve fecal incontinence due to external anal sphincter injury may be delayed, presenting years after delivery, and initially intermittent because surrounding pelvic floor muscle and connective tissue can compensate for the injured external anal sphincter and maintain continence. However, with age-related atrophy of the pelvic floor muscle, fecal incontinence can become increasingly frequent and severe. On examination, patients typically have decreased anal sphincter tone and asymmetry. Decreased anal sphincter tone, first of all, and decreased anal sphincter tone and asymmetric anal wink. Anal wink reflex is S3 and S4. Patient with large sphincter injury may have palpable defect. The diagnosis is confirmed by anal manometry or endoanal ultrasound. Uh, this is very high yield that anal manometry and endoanal ultrasound can confirm these fecal anal fecal incontinence. Initial treatment is dietary modification, bowel training, antidiarrheal medication. Surgical repair is based on symptoms, severity, and patient's preference. Dietary modification, bowel training, and antidiarrheal medication, and surgical repair is based on the severity, symptom severity, and patient's preference. Okay, now genital warts. Genital warts, also known as condyloma acuminata, usually happens by HPV 6 and HPV 11. In here there is multiple pink or skin colored fleshy lesion. This is first talk. Multiple pink or fleshy colored skin lesion ranging from smooth flattened papule to exophytic cauliflower-like growth. Lesion ranging from smooth flattened papule to exophytic cauliflower-like growth. Treatment is for what? Podophyllatoxin, uh, triachloroacetic acid, and immunologic is imiquimod. Surgical, cryotherapy, cryo, laser therapy, and excision can be done. Vaccination and barrier contraception should be done. Patients with chronic tobacco use or immunosuppression have elevated risk of this type of lesion. This type of exophytic, dry appearing verrucous, cauliflower-like, although there may be appear as sessile or flat. Most lesions are exophytic, dry appearing verrucous and cauliflower-like. This is cauliflower-like verrucous. This is cauliflower-like verrucous lesion. Verrucous cauliflower-like, although some appear sessile and flat. Genital warts typically asymptomatic, although pruritic and non-tender. This is non-tender pruritic friable lesion. Those bleed on manipulation and may occur. Diagnosis. Diagnosis primarily is clinical. Diagnosis primary is clinical. Look at this picture. Okay, diagnosis primary is clinical. Based on characteristics appearance on the lesion, we can use these three things for chemical podophylotoxin, podophyllin, resin, trichloroacetic acid for chemical, immunologic, imiquimod, and surgical cryotherapy, laser therapy, and excision. Congenital word, condyloma acuminata in children, human papilloma virus, sexual abuse, autoinoculation from other side, prenatal and perinatal, pink, fresh colored, this is fresh colored, verrucous, papule, and black. Asymptomatic is most common pruritic fibril lesion. There is pruritic fibril lesion in anogenital word. Sexual abuse assessment, especially age more than 4. Sexual abuse assessment should be done if you find an anogenital word in a 6 or 7 years old baby, then you have to do sexual abuse assessment. However, because of the association with transmission by direct genital contact, an assessment of sexual abuse is required in children, particularly age more than 4. This is high yield. This is Bartholin duct cyst. Bartholin duct cyst. Skinny gland. This is urethral meatus. This is labia minora. This is labia majora. There is cyst or abscess. This is normal Bartholin gland. In here, if there is cyst or abscess in 4 o'clock and 8 o'clock position, 4 o'clock, 8 o'clock position to provide vulvovaginal uh, Bartholin glands are located bilaterally. It is located in here and in here bilaterally at the posterior vaginal introitus and have ducts that drain the vulvar vestibule at 4 o'clock, 8 o'clock position to provide vulvovaginal lubrication. The Bartholin gland are not palpable unless ductal blockage occurs. It is not palpable. Bartholin gland is not palpable unless the ductal blockage occur, resulting in mucoid filled buildup and cyst formation. The Bartholin gland ducts. The Bartholin gland ducts may become obstructed either from accumulation of the mucus or secondary to the edema or trauma. Though may though many cases are idiopathic, it may be idiopathic. The soft, mobile, non-tender cystic mass can be asymptomatic, may found incidentally at the base of the labia majora with posterior with possible extension into the vagina. This is soft, mobile, non-tender cystic mass may be found at the base of the labia majora. It may extend to the vagina. With sufficient enlargement, it may cause discomfort during walking, sitting, and sexual intercourse. Bartholin gland cyst or abscess can cause discomfort during walking, sitting, and sexual intercourse. During walking, sitting, and asymptomatic Bartholin gland cysts in women do not require an intervention, and most of the cysts drain spontaneously, resolve on their own. Therefore, observation and expected management are recommended. Treatment is incision and drainage, followed by a placement of the ward catheter to reduce the recurrence. Some women recurrent Bartholin gland cysts are absent and mars marsupialization procedure, which creates another point of drainage for the Bartholin gland. Marsupialization procedure, it actually creates another point of drainage for the Bartholin gland. Broad spectrum antibiotic therapy for Bartholin cyst is recommended. For Bartholin abscess, only if there are signs, fever, and risk factor pregnancy, immunocompromise for systemic infection. Vulvar biopsy is indicated in patients with positive full Bartholin gland carcinoma, which typically presents as a mass, solid fixed mass in older women, solid fixed mass in older women. Then Gardner duct cysts and skinny glands. In Gardner duct cysts results in incomplete regression of the Wolffian duct. In Gardner duct cysts, there is incomplete regression of the Wolffian duct during fetal development. The cyst appears long on the lateral aspect of the upper anterior vagina. In contrast to Bartholin gland cysts, they do not involve the vulva. These cysts appear along the lateral aspect of the upper anterior vagina. They do not involve the vulva. Gardner duct cyst is incomplete regression of the Wolffian duct, and skinny glands, bilateral paraurethral glands in the anterior vaginal vestibule. Skinny gland cysts may form with duct obstruction. It would be located lateral to the urethral meatus. Then vaginal hematoma. In vaginal hematoma, operative vaginal delivery, infant more than 4 kg or 8.8 pound, nulliparity, prolonged second stage of labor. These can cause vaginal hematoma. This is another IL topic. This is mm, this is another IL topic, that is vaginal hematoma. It's an vaginal hematoma operative vaginal delivery, infant more than 4 kg, nulliparity, and prolonged second stage of labor. It can come with the complaint of vaginal mass, rectal or vaginal pressure, with or without hypovolemic shock. Non-expecting observation, expecting embolization for hematoma. Embolization and the surgery. Vaginal hematoma is a life-threatening postpartum complication. Vaginal hematoma is a potentially life-threatening postpartum complication that presents with vaginal mass and possible hypovolemic shock due to massive occult bleeding, very high yield. It can come with vaginal mass and possible hypovolemic shock due to massive occult bleeding. During delivery, stretching of the vaginal canal can injure the uterine artery, and particularly in the nulliparous woman undergoing operative vaginal delivery, forceps assisted, or delivering an infant of more than 4 kg baby. The resultant injury can cause massive postpartum bleeding as the uterine artery during pregnancy enlarges and supplies as the uterine artery during pregnancy enlarges and supplies the uterus up to 30% of the total cardiac output. Because the blood collects in the paravaginal space, patients often have massive occult bleeding evidence only by hypovolemic shock initially. The resultant injury can cause massive postpartum bleeding as the uterine artery As the uterine artery during pregnancy, as the uterine artery during pregnancy enlarges and supplies the uterus up to 30% of the cardiac output. Because the blood collects in the paravaginal space, a large potential space, a large potential space. Patient often have massive occult bleeding evidence only by hypovolemic shock, hypotension, tachycardia, and diaphoresis. However, as the blood continues to collect within the paravaginal tissue, patient can develop protruding vaginal mass often associated with rectal or vaginal pressure and minimal bleeding. Now, vaginal tumor. This is a picture of the vaginal tumor or vaginal cancer. It is age more than 60, HPV, the bad HPV 1618 is the cause of this type of tumor, tobacco use, and in utero if there is use of diethylstilbestrol exposure. Diethylstil uh, still bestrol only causes clear cell adenocarcinoma. and the rest of the uh, probably squamous cell carcinoma. Okay, I will look that below. That vaginal bleeding, there may be bleeding, there may be malodorous vaginal discharge, and irregular vaginal. This is irregular vaginal lesion. From here, you should take a biopsy, surgery, and chemoradiation should be done. Lesion typically appear lesion typically appear in the upper third of the posterior vagina. Lesion usually appear in the upper third of the base. Next step is the biopsy of the lesion. The biopsy evaluate the depth of the lesion, depth of the invention. Biopsy depth of the biopsy actually evaluate the depth of the invasion of atypical cell and differentiate between vaginal intraepithelial neoplasia and vaginal cancer. Patient with non-invasive disease can be treated conservatively with topical therapy with a wide local excision with a wide local excision. Patient with non-invasive disease can be treated conservatively with topical therapy with or non-invasive can be topical or wide local excision, and invasive should be surgery and chemoradiation should be done. And for invasive extensive procedure, radical hysterectomy extensive procedure, radical hysterectomy, vaginectomy, and pelvic lymph node dissection and chemoradiation. And chemoradiation should be done. Chemoradiation should be done. Okay, vaginal cancer, persistent HPV, chronic inflammation, tobacco, vulvar lichen sclerosus. This is high yield. It can cause vulvar cancer, vulvar pruritus, plaque, and bleeding. Pruritus, plaque, and bleeding. Biopsy should be done. Biopsy should be the next step. So, patient with history of sclerosis means thickening and hardening. There is a picture of lichen sclerosus. You can see in here. This is the picture of lichen sclerosus. Thin, oh, there is thin white, maybe pinkish, wrinkled skin over the labia majora and labia minora. Atrophic changes that may extend over the perineum and around the anus. Excoriation, erosion, fissure from severe pruritus. In here, you should do biopsy. Punch biopsy should be done in here too. In lichen sclerosus, vaginal cancer, the risk factor, one of the risk factor is lichen sclerosus, tobacco, immunodeficiency, prior cervical cancer. It requires a vulvar biopsy. There may be friable palpable ulcer. It can friable palpable ulcer on the labia majora, and there is intermittent bleeding. Dyspareunia may happen. Patient may Dyspareunia may happen. Vulvar biopsy actually differentiate benign lichen sclerosus or neoplastic disease. This is important. It is also helps to differentiate the depth of the invasion uh, and non-invasive VIN versus VC. Patient with VIN, imiquimod or laser ablative therapy can be given. Vulvar sclerosus lesions are typically multiple white plaques that converge into a multiple white papule that converge into a plaque. Okay, prolapse, pelvic organ prolapse. In POP, pelvic organ prolapse, and maybe anterior prolapse, anterior maybe bladder, cystocele, posterior maybe rectum, rectocele, and in small intestine can be prolapse. This is called enterocele, and apical prolapse, uterus and vaginal vault. Apical prolapse means uterus and vaginal vault prolapse. The procedentia means complete prolapse. Complete herniation, complete prolapse is called procedentia. Why this pop can happen? This pop can happen due to if the patient is obese. First, if the patient is obese. Second, if there is hysterectomy. Hysterectomy, the high yield is hysterectomy. If the patient is obese, if there is hysterectomy. Multiparity, obesity, multiparity hysterectomy, menopause. Obesity, multiparity hysterectomy, and menopause. It may be asymptomatic. Incidental finding may be vaginal or pelvic pressure. There may be obstructed voiding. There may be urinary retention. If there is anterior, if there is anterior prolapse bladder cystocele, it can cause in cystocele. It can cause urinary problem. If there is rectocele, it can cause fecal urgency, fecal incontinence, and constipation can happen. It may cause sexual dysfunction. Procedentia means complete herniation and apical polyps, uterus and vaginal wall. Management asymptomatic observation, symptomatic pelvic floor muscle exercise, vaginal pressure and surgical repair. It occurs due to herniation of the pelvic organs into the vagina. Herniation of the pelvic organ occurs due to damage of the levator ani muscle complex. Due to damage of the levator ani muscle complex. The decreased pelvic floor support causes an anatomical change to the normal pelvic organ position from the rectum. It leads to change in the rectal angle during defecation, which can incomplete defecation and constipation. With accumulation of the fecal material, uh, the rectum expands and herniate. Rectum expands and herniate through the rectovaginal septum and causing prolapse into the rectum into the posterior vaginal wall rectocele. With increasing age, the herniation can progress and resulting in development of vaginal pressure or a vaginal mass worsens with pulse of a maneuver like voiding. Patients often report that having to reduce the herniated vaginal mass splinting to void or defecate. Examination also stages the extent of the individual organ descent and guides the management. Some patients can develop vaginal erosion as a prolapsed vaginal wall protrudes past the hymenal ring, rubs with against the clothing and becomes denuded and friable and causes abnormal bleeding. Uterine procedentia, complete pelvic organ prolapse in which entire uterus herniates through the vagina along with the anterior and posterior vaginal wall. POP may be asymptomatic, do not require treatment, but however, when patients have symptoms such as pelvic pressure, bowel bladder dysfunction, sexual dysfunction, erosion, surgical and non-surgical management can be given. Surgical management is anterior vaginal wall repair, conservative treatment, non-surgical management, pressure can be used in post-surgical candidates like heart failure, extreme age, poorly controlled diabetes. In those patients, conservative management is preferred. Surgical should not be given. Complete herniation requires mechanical correction, pressure or surgery. Uterine leiomyomatous can cause POP if the numerous are large enough to weigh down through the uterine. Leiomyomatous can cause pelvic organ prolapse. Urethral diverticulum may present with urethral diverticulum. Mm. Now, urethral diverticulum. In urethral diverticulum, the urethral mucosa herniated into the surrounding tissue. If urethral mucosa herniated into the surrounding tissue, it is called urethral diverticulum. In here there is dysuria, dribbling, dyspareunia, dyspareunia, and and anterior vaginal wall mass. An anterior vaginal wall mass. If this type of thing is present, it is called urethral diverticulum. Urine analysis, urine culture, MRI of the pelvis, and transvaginal ultrasound should be done. Transvaginal ultrasound should be done. The recurrent infection and inflammation of the urethral tissue. The recurrent infection and inflammation of the urethral tissue create an abdominal outpouching that can collect and store urine, result in post-viral dribbling and recurrent lower urinary tract infection. Tract infection. Infection of the urethral diverticulum can result in tenderness, often presenting dyspareunia, tender anterovaginal wall mass with associated with expressed purulent or bloody urethral tissue. Diagnosis is confirmed by pelvic MRI. So this, if a patient comes with dysuria, dyspareunia, dribbling of the urine, post-viral dribbling of the urine and anterovaginal wall mass, you do MRI of the pelvis and diagnosis confirmed and diagnosis done. This is urethral diverticulum, outpouching of the urethra. This is urethral diverticulum. This is the urethral diverticulum. This is outpouching in here the urethra. It is confirmed by MRI and treated by surgical excision of this outpouching. Surgical excision of this outpouching. Overflow incontinence can cause dribbling, but there will be high post-vital or residual volume and no mass. Now, Bartholin gland abscess can present Bartholin gland abscess can present as tender valvular mass that expresses purulent. I have already discussed on this Bartholin gland abscess. It is 4 and 8 o'clock position, not along the anterior wall. Then interstitial cystitis, chronic bladder pain syndrome. Interstitial cystitis, more common in women associated with psychiatric and pain disorder, fibromyalgia. Bladder fibromyalgia is called interstitial cystitis, chronic bladder pain syndrome. Bladder pain with filling, bladder pain with filling and relief with voiding. Bladder pain with filling and relief with voiding, increased urinary frequency, urgency, dyspnea. Bladder pain with no other cause more than 6 weeks, normal urinary lysis, not curative. A focus on improved quality behavioral modification, avoidance of the trigger, physical therapy. Amitriptyline, pentos, and polysulfate sodium can be given. Analgesic can cause analgesic for acute exacerbation. Interstitial cystitis, IC, also known as chronic uh, painful bladder syndrome, is a chronic painful bladder condition of unknown etiology. In here, management of the precipitating factor like avoidance of caffeine, alcohol, artificial sweetener. Its immunolysis, post-viral disease, sexually transmitted infection screen is performed to exclude other cause of cystitis, urinary obstruction, malignancy, but usually negative. It's one sort of a functional disorder. It is also known as fibromyalgia of the bladder. That is the third part of the Ops and Gynecology series. Hope you enjoyed.